Hi, I'm Laurie Thomas, and I'm the manager of Healthy Aging for Maricopa County Department of Public Health. And we welcome you to the afternoon session of our annual conference for Health Literacy 2021. Social isolation, COVID-19 impact and outreach. We have three phenomenal panelists from three very different sectors, and all three panelists represent very different but deeply affected by COVID-19. Our first panelist will be Zeta Diedolf. She's the Director of Health Policy at Children's Action Alliance. She works towards health justice for children and families at local and state and federal levels. She holds a Bachelor of Science degree in anthropology and bioethics from Loyola University in Chicago and a master's degree in public health from the University of Arizona. Next, we have Chiquita Taylor. She's the Executive Director of FIBCO Family Services, which stands for Facilitating Independence and Building Comprehensive Opportunities in Phoenix. Chiquita has had leadership roles with National Institutes of Health at Woodmont House and also the Girl Scouts in Arizona, Cactus Pine, and the International Rescue Committee. Chiquita is a graduate of the University of Maryland and a Bachelor of Science in Public Health. And we have Dana Marie Kennedy. She's the State Director of AARP Arizona. And Dana has served more than 25 years as a leading advocate for working families, retirees, and women at the local, state, and national levels. Kennedy holds a bachelor's degree in social work, as well as a certificate in gerontology from California State University. She has a master's in social work from Boston University, where she also acquired certificates in human service management and gerontology. She's also served as an advisor for the mayor of Phoenix, Arizona governors, and congresspersons. And with that, I will go ahead and turn it over to Zeta Diedolf, Director of Health Policy at Children's Action Alliance.
Thank you so much, Laurie. I appreciate it, and I'm glad to be here with you all today. Could you please advance the slide? So I wanted to talk a little bit about kind of where Arizona stood when it came to children and children's health, as well as public health on a more general level before the pandemic hit us. So these are some of the headlines that we've seen over the past 2 or 3 years prior to the pandemic. As you might have picked up, we do not invest in public health as a state during the best of times, and we tend to rank towards the bottom for adverse childhood experiences, health insurance enrollment, and any slew of other negative factors that can impact children's health. Next slide, please. So I've broken down here Arizona's child population by race and ethnicity. And as you can see, we're pretty evenly split between children who are Latino or Hispanic and children who are white, non-Latino or Hispanic. And then we also have about 5% American Indian Alaska Native population, 2.5% Asian, 4.4% Black or African American children, and then 7.7% some other race, which can be either, occasionally we'll see people kind of identify across racial and ethnic lines, particularly when it comes to the census. And so it gets a little muddy in there sometimes when it comes to self-identification, and that's something that we can definitely work on at the census level. And then about 6% of our kids are 2 or more races. Next slide, please. When we look at our poverty rates, we really see an inverse of that, right? So particularly when we look at this big green bar over here on the left, this is our Indigenous population. About 64% of Indigenous children in Arizona live below the poverty level. We also see a disproportionate number of Asian and Pacific Islander children who are living in poverty compared to the percent of that they represent of the total population. Hispanic or Latino as well, higher than you might expect. Non-Hispanic white children, lower than you might expect given their percentage of the population. And then our Black or African American children actually weren't included in this particular image because of a data suppression issue, I believe. But do tend to be slightly higher than other populations as a whole, or than their percentage of the child population as a whole. Next slide, please. When we look at who is covering our kids with health insurance, about 35% of children in our state are enrolled in Medicaid, or Access is what we call it here in Arizona, as I'm sure many of you know. About 44% have employer-sponsored healthcare through a parent. And then we have a smattering of other types of healthcare as well, either through military VA, Medicare, or direct purchase through a health insurance company or the exchange. Next slide, please. And I also just want to look at who's uninsured in our state, just to kind of lay this groundwork once again. This is data from the 2019 American Community Survey that the census put together. And it showed that almost 1 in 4 American Indian or Alaska Native is uninsured in Arizona. And this is specific to the child population. Just as a quick point of clarification, children who only receive healthcare through the Indian Health Service, through Tribal 638 facilities, or through urban Indian health programs, but who do not have a source of coverage beyond that, are considered uninsured for purposes of the census. And we could talk about that all day, but I did just want to kind of stress how many of those children are uninsured compared to how many would be likely Medicaid eligible based on income. We also have seen the rate of uninsured Asian and Pacific Islander children in our state more than double in recent years. So this is definitely trending in the wrong direction. We do see a high proportion of uninsured Hispanic and Latino kids in our state relative to the greater population as a whole, if that makes sense. So we know that 11% of Hispanic or Latino kids are uninsured, but we also know that they represent such a huge proportion of our population as a whole that that's a tremendous number of kids. Across the board, we can see that people of color, Black, Indigenous, and people of color children are uninsured at a higher rate than our non-Hispanic white children in Arizona. Next slide, please. So there are a lot of things that kind of factor into this, and if you're going to kind of guess which children might be uninsured, these are some of the factors that play into it. So age is a huge one. Once kids get out of that toddler stage, once they stop needing those quarterly or annual checkups, they tend to fall off of coverage. And we see a really steep decline when kids hit about 12 or 13 in Arizona. Geography is also huge. So there's a big rural urban divide. In a lot of places, there just aren't opportunities to enroll. There aren't as many assisters available in person or in facilities that can help with health insurance enrollment. And there are other barriers as well, such as broadband access and other things as well. So, and then parent coverage status. So this is huge. When a child's parent has health insurance coverage themselves, it is much more likely that that child will be insured and stay insured. Income is another huge factor in Arizona across the board. We have, though we have expanded Medicaid, we have fairly low income eligibility thresholds for our CHIP program in particular, as well as for our pregnant and postpartum category within our Medicaid program. And so what we find is that a lot of the people who are uninsured are earning just a little bit too much to qualify for Medicaid or for access or for kids care, as we call our CHIP program in Arizona, but probably not enough to realistically afford a private source of coverage. And so we're working on a ton of things related to affordability. There have been some federal changes, but that, $2,000 deductible can still be a huge barrier to families when it comes to getting healthcare through the marketplace or through a private insurer. And then culture. I think that we tend to take for granted that health insurance is this universal thing that everyone practices and that everyone has, and it's definitely not. And particularly in the US, our healthcare system is absolutely baffling to a lot of people, myself included. And so when we look at, how people were raised, the communities and cultures that they come from, it is not true across the board that everybody has even a basic understanding of what health insurance is. And quite frankly, I've talked to a lot of people who the first time they heard about it thought it was a scam, because it kind of sounds like it. If you pretend you've never heard about health insurance before, what do you mean you're going to give me insurance for my health? So go ahead and go to the next slide, please. So in the short term, I talk about poverty, I talk about health insurance coverage because this has both immediate and long-ranging impacts on children's health and on adult health. So one of the things that I just want to talk about for a moment is EPSDT, that's early and periodic diagnostic screening and testing. This is basically a guarantee in the Medicaid system and in CHIP that children who are covered by Medicaid and who are covered by Access will have their healthcare needs met. And so our Medicaid system sets up standards and kind of guidelines for what that means, for what it means to meet a child's healthcare needs. But at a bare minimum, I like to just kind of clarify that means that this child will have access to routine visits into well child care during the duration that they're covered, that they'll have access to vision and dental care. That's huge. That they'll be able to get those vaccinations on time, and that they'll have access to any kind of developmental screenings that they might need, as well as referrals out to services that might benefit them in the long run. Next slide, please. And just to kind of compare Medicaid employer-sponsored health coverage and being uninsured. This is a survey from the Kaiser Family Foundation that was done a couple of years ago that found that pretty much across the board, particularly when it comes to having a medical home, having a usual source of healthcare, being able to access that well child visit, and even to an extent being able to see a specialist, that children who were covered by Medicaid were pretty much on par with people who had employer-sponsored health coverage. And that's huge, especially when you look at that compared to this, I guess, brighter blue line down here, the cobalt line, which is our children who are uninsured. They're less likely to have that routine source of care, to get those checkups, and to be able to see a specialist when they need one. Next slide, please. And then this is really the big picture for me, right? So when we talk about children having access to healthcare and having access to health coverage in their childhood, what that translates to is reduced morbidity and mortality in early adulthood. It means less chronic illness. It means higher on-time graduation rates from high school, as well as higher participation in continuing education, higher education. It's an investment that pays for itself by the time that a child turns 36. So that investment comes from that increased economic mobility, from higher tax payments and less use of earned income tax credits in adulthood. And then also, particularly when we look at children who are covered into their adolescence, they earn more as adults, first of all, and their children tend to be of a healthier birth weight in the next generation. So this is not just a one-off intervention. It's not just about getting our kids covered today. It's about looking generationally and making sure that we're making that impact. Next slide, please. So now there's this global pandemic, and this is where we're at. We're seeing, we really didn't have this foundation laid to help address a pandemic of this magnitude, to help address any of these problems that we're seeing. And one of the big problems that we've seen now is that children are making up a larger share of COVID cases, particularly with the new Delta variant, and then also that, can you hit next again? Thank you. That we're seeing this relationship between our state level policy interventions, where we're putting our money, where we're putting our efforts, and the rate of children and families who are being impacted. And then lastly, I just want to clarify one more thing. Can you click once again? Thank you. This is the hugest part and what I want to talk about, and that is that during the pandemic, we have seen a tremendous decline in access to care for children, particularly who are enrolled in Medicaid and CHIP. This is due to a lot of factors. I spend a lot of my time talking to families who are enrolled in Medicaid and CHIP, and And one of the things that they have mentioned is just fear, right? Like we know that our lower income families are being hit hardest by this pandemic. Our families and who are Black, Indigenous, and people of color are being hit especially hard by this pandemic. And also, I think inadvertently, some of the things that we've erected to help slow the spread of the virus inadvertently wind up presenting barriers, particularly to low income families. So just one example, we do a lot of work. One of our parent advisors has 5 children. Her pediatrician's office only allows her to bring in 2 of them at a time. So for her to bring in all of her kids for their routine checkups or their routine vaccinations, it means that she has to take 3 days off work. And that is huge. That's a huge ask for any working parent, particularly if you don't have transportation, but especially now that we have some restrictions in place. Next slide, please. So this is the big picture when it comes to keeping kids connected to health coverage. Children across the board missed routine care in 2020. We saw, generally, I think we've turned to telemedicine in this time, and telemedicine is a tremendous tool. It's also not frequently not an appropriate tool for use in the pediatric setting. And so what we see is that not a lot of pediatric visits are conducted via telemedicine. Not a lot of appointments are given that way. And we do see huge disparities when it comes to being able to access that telemedicine infrastructure to begin with. There's some care, particularly when we're talking about, for example, hearing tests or developmental screenings that just can't be delivered remotely. And also we've seen fewer eyes on children's development. So we've had kids who, maybe their childcare teacher might have noticed something a little off about their verbal development and might have spoken to the teacher about it, but less eyes on that kid means less referrals overall. And across the board, we also saw that children who receive health coverage through Medicaid and CHIP experience this at an even greater rate. So they have been more likely to miss routine healthcare, and they've been slower to return to that baseline than other populations. And I just want to clarify, this pandemic is not over. These kids have fallen behind and are still lagging behind, and we need to make sure that any recovery that we invest in is making significant investments in health infrastructure that are going to target those kids who need it the most. And one of those things just absolutely must be health coverage. Next slide, please. So this is kind of a point in time from last winter. I believe it was in December, they looked at a 2-week period compared to the prior year before the pandemic and saw a 24% overall decline in pediatric visits as a whole. And that was the steepest decline among all of the specialties. Next slide, please. Arizona, this is from the Centers for Medicaid and Medicare Services, who administer Medicaid and Medicare and CHIP. But we had some of the lowest vaccine rates, particularly for children under 2 as of May 2020. So, right at the beginning of the pandemic, we were already behind, and we know that we haven't caught up. Next slide, please. And then again, Arizona is the purple line on here. We've had some of the lowest rates of mental health services delivered via telehealth. And we know that some of that is structural. We know that some people don't have access to the tools that they need, or the broadband, or whatever it might be to use telehealth. And we also know that that this is a tool that has become critically important right now, particularly when it comes to getting care into rural and more remote areas. Next slide, please. And I want to just pause here and talk about the impact on adverse childhood experiences. And so this is a really big number, 113,708. This is the estimated number of children as of April 30th of this year who had lost at least one primary caregiver, a parent or a primary caregiver who was a grandparent due to the pandemic. So what we, what we're seeing now is these children are encountering trauma, and it's a critical point where we need to be intervening and we need to be wrapping around the services that they need. We know that these children are disproportionately children of color, that they're disproportionately Indigenous children, and that they are going to be coping with that loss and coping with that trauma for many years to come. And so I wanted to just lay that out there. Next slide. Thank you. So I kind of put what we need to do to help get everybody back on track into 3 buckets. One of them is affordability. We need to make Medicaid and CHIP available to families who qualify. We need to raise our income caps. We need to cover immigrant children. Right now, if you are a green card holder, you have to wait 5 years of residency in the US before you can qualify for Medicaid or CHIP. We know that that would make a huge difference to families who are taking all of the steps that they need to take to become citizens, but who haven't yet met that 5-year bar. We need to also build upon the Affordable Care Act. So one of the things that we saw that really spurred enrollment in healthcare over the past, since January of this year, I guess, is that the Affordable Care Act marketplace reopened, and it opened for a long period of time, and there was a ton of money that was poured into it for outreach and for advertising and for making sure that everybody who knows, everyone who needed it could become aware of the fact that that was an available tool. It also increased the subsidies that are available to people and extended them so that now families that earn slightly higher still can qualify for some help through the federal government with paying for healthcare. We do still see what they call the family glitch though, and that is it's something that we really need to fix at the federal level. So when somebody receives healthcare through their employer, the employer is required to make it affordable. There are some standards that they have to meet to the employee, but not necessarily to the family. And so for a lot of people, covering their families through their employer-sponsored health coverage comes at a tremendous cost. Because that family theoretically has coverage available to them, they're not eligible to purchase healthcare through the Affordable Care Act marketplace. And so we need to fix that. We also need to work on cutting some of the red tape that we see, particularly in our state when it comes to families. There's so much paperwork that you have to do to apply. I don't know if any of you have ever gone through this. It's a lot of paperwork. It's very high level. As I mentioned, when we talk about health literacy, it's definitely not written in an approachable, accessible way for families. We also see this issue where we're requiring ongoing eligibility checks. So families aren't just going through this paperwork one time, they're having to go back and provide pay stubs and rent checks and whatever else it might be over and over and over again throughout the year. We can provide 12 months of continuous eligibility. We can get kids into coverage and cover them for the whole year. It's very easy to do. And I'm hoping that that's something we can work towards. We also right now have kids wait 3 months before they can qualify for CHIP. And that, in design is supposed to prevent them from, jumping off of their employer-sponsored plan and onto a CHIP plan, but it winds up being a problem for a lot of families when they do lose coverage or maybe when they experience some kind of medical emergency. And then the other thing that I just want to add is, we really need to make continued investments in our health infrastructure, not just in public health spending per capita, though that is a huge, huge thing that we need to do. We also need to be looking at health as determined by all of those social determinants: access to clean water, access to affordable healthcare, access to broadband internet, and the like. And then we also, I think that underlying all of this is a need for ongoing health education in our schools, in our families, and in the community. Lastly, I just want to add that there's a notion of accountability here. So we pay for healthcare whether it's being delivered through Medicaid or not. So we're paying for these costs either through our tax dollars as Medicaid or CHIP coverage, or in subsidies to healthcare facilities and providers and other types of folks for uncompensated care and for those preventable illnesses that can't get treated due to the cost barrier that turn into emergencies down the line. Right now in Arizona, we have very limited access to data on who is enrolled in our healthcare programs, in our Medicaid and CHIP program, and in terms of who is able to access the services that they need. So it's hard to go through and map the barriers if we don't know who's actually able to get into the services now and where they're receiving them. And I will just add that, you know, wherever we can, we really want to see that data disaggregated by race and ethnicity, so that we can better categorize where we need to be devoting that kind of effort to outreach and enrollment and education, as well as where we need to be placing providers, if that makes sense. So I think that that's my last slide. So I'm just going to say thank you so much. I put my contact information on the next slide. I think if you'd like to reach me, feel free.
Zeta, thank you so very much. We did have a question, and one of them was on a slide that occurred right before your uninsured slide. If we could go back to that. It was about, the question was the purple vertical bar did not show specific demographic group. Could you explain that?
Yeah, I'll have to look into that. I believe that what happened there could have been suppression due to sample size. So it could be that, or it could be just that we don't have great up-to-date census data. So we really try not to just pull data from wherever. We really want to make sure that it's as accurate as possible, and that occasionally means that we aren't able to showcase everybody with a high enough like level of accuracy or a low enough margin of error. And so if you were interested in this, I could go to the census data. If you want to shoot me an email, I can look it up for you and see, you know, roughly where we would be at for our African-American kids, our Black and African-American kids. But it's not coming across on the slide right now.
Okay, thank you. Another question was, are you getting COVID funds, and what will you do with those?
So that's a tricky question. Children's Action Alliance really focuses on the policy and advocacy side of things. So we don't do direct service. We're not handing out flu shots or anything like that. But we do a fair amount of outreach to communities, either through paid media. We do social media, we do radio, we do I'm forgetting one of the big ones. Oh, like digital ads. We've done bus ads. And lately we've been doing a lot of partnerships with kind of like identifying individual influencers in communities that we know are underrepresented in health insurance generally, and partnering with them, paying them to promote health insurance as a whole. I will say federal funding for that really dried up for a long time there. And so a lot of that work has been sustained kind of by like pulling together little scraps of funding here and there to make sure people understand the options that are available to them. And I think it is also very clear that also had an impact on people's ability to seek navigator services, to find that person in their community at that place that they trust, that they can go to, who can help them figure out what the best healthcare option is for them. We are starting to see some of that money come in again with COVID funding, as well as on an ongoing basis for healthcare.gov and other things like that. So,
thank you. And I think there's one last question. What type of outreach are you involved in to help provide support to children who are affected by social isolation?
Sure. So we have a director of early childhood policy, or I'm sorry, not early childhood, child welfare policy, thank you, who does a lot of work in particular with this side of things. On our end, in kind of more the healthcare space, we're really looking at access to healthcare, access to behavioral healthcare, particularly for kids. One thing we find is that, especially in our rural regions, our state as a whole is an underserved area when it comes to behavioral healthcare. I guess I should say that. But particularly when we look at our rural regions, it's had a tremendous impact on children who go to rural schools because they haven't been in school, and often that school has a connection with a behavioral health agency or facility that can service them either through an IEP or through another arrangement with Medicaid. And for a while they weren't having access to that. And so that would be a huge thing that we're looking at, always looking at workforce, particularly in tribal regions, because that's huge, and Indigenous Arizonans just don't see themselves represented in their own healthcare systems. It's hard to get people to go work at rural, remote, tribal health facilities. Often housing can be a big issue. So kind of looking at all of those bigger systems level barriers that are preventing people from entering the workforce, and then preventing people from accessing care through the systems that we do have in place, is probably where we're most active.
Another question came in. Does your organization have health navigators?
We do not, but we are part of a coalition called Cover Arizona that is really dedicated to making sure everyone can find that. I'm really happy to say that over the past few months, we've been able to transition our phone hotline over to 211. So we now have promotorials and community health workers who are working full-time in positions at 211, who are answering the phone and who know what questions to ask to get somebody into a healthcare facility. Any of our FQHCs statewide, and I believe all of our tribal healthcare facilities have some kind of healthcare navigator, benefits coordinator, health insurance outreach specialist, et cetera, who can help people navigate that process. And if you visit either the website coveraz.org or call 211, you can get connected, and they'll actually schedule an appointment for you with a navigator.
Wonderful. Thank you so much, Zeta Didolf. Thank you with Children's Action Alliance. Thank you so very much.
Thank you.
And we appreciate all the information you've given us. Next, we have Chiquita Taylor, the Executive Director of FIBCO Family Services. Take it away, Chiquita.
Great, thank you so much. I am delighted to be here today. I would like to share FIBCO's experience in addressing vaccine hesitancy through community engagement. So next slide, please. I will start off by sharing FIBCO Family Services mission, a little bit about what we do. So our mission is to provide people with knowledge, skills, and support to transform and empower their lives. We are the community outreach arm of First Institutional Baptist Church, which is located in downtown Phoenix. We strive to have an impact in the lives of individuals in areas such as food, clothing, housing, immigration assistance, and lately in health and health care. So FIBCO has helped throughout the COVID-19 pandemic in various ways. In early February, we had our virtual community health fair, which was a series of 29 workshops where we highlighted different health topics. One of those was COVID-19. And so we had a panel of 4 African-American physicians that provided information about COVID-19 and the vaccine. Now, this was very important because early on, we had a lot of information that was changing daily. And so this provided an opportunity for people to ask questions in an environment where they felt safe. And so following that event, we were approached by Mayo Clinic. They were looking for a partner that was trusted, that had the community's trust, to really engage, educate, and provide vaccine access to the underserved community, so communities of color. And so we came together along with Mayo and other churches, community service organizations, and other entities to plan a pod vaccine event. We really brainstormed on, what the barriers were to get access to vaccine. And so my presentation is just highlighting some of the things that we learned through this process. So next slide, please. So some key points for increasing vaccine confidence through community engagement. We hear the term the trusted messenger. So similarly to how Mayo Clinic approached us, we are the outreach arm of the church. Pastor Stewart is well known in the community as a leader that advocates. And so we do have a strong presence in the African American community. So it was important to find, partners like us to provide messaging to the community. Also, equitable access to vaccine, those barriers I mentioned before, really brainstorming, bringing everyone to the table and seeing what they could bring to kind of bridge the gap and allow for us to provide vaccine to individuals. And then lastly, gathering and assessing data. We know that large organizations, CDC, does a wonderful job of capturing data and sharing data. But we as community organizations also have an opportunity. We have, daily interactions with the community. We're having conversations. Why not gather this information and assess it to better serve the community? So I will be going into more of this information in the following slides. Next slide, please. So trusted messenger, what does this mean? Basically, the people that the community wants to hear from: faith leaders, elders, community advocates, such as promotoras, people that are already advocating in the community. They know the cultural nuances. They are able to get education and bring it back to the community. And there's trust there. That's why it's important. Community organizations like FIPCO, the community already knows that we provide resources. So why not partner with the experts to provide information that is accurate and they are able to understand? Word of mouth. Word of mouth is very important. The pictures shown here on the slide are of our event. I will share a story of an example of word of mouth. We had a young lady stop by. She was undocumented and a little bit weary of presenting her ID. And so she asked me, would it be okay for my mom and my friends to come to this facility? I said, absolutely, as long as you have some sort of ID, identifying who you are, we're able to serve you. And because she saw that there were people that looked like her and people that understood her language, she felt comfortable. And the next day she returned with other family members. So very important. Meet them where they're at, empathy and understanding. So again, we're out there in the community hearing stories. It's important to listen and validate what people are saying. The fear is real. The historical experiences are real. So, we validate that and then we assess what resources are available. For instance, if someone is saying, they're scared of the symptoms, we could provide resources and then schedule for a time for them to meet with a physician. If that's not the right choice, maybe they meet with us again and we go over, what can be done. It's just important to provide that empathy and not, let the person know that it's okay not to be ready to make the next decision. Next slide, please. Equitable access to vaccine. So location of healthcare centers, Maricopa County has been doing an excellent job of partnering with various organizations to make sure that locations are centralized and accessible to individuals in the community. We were a pop-up vaccine site in early April. The picture on the right is a picture of some of our housing residents coming through the Lyft station. So we had a great partnership with Lyft. We learned through this process that many of the individuals are, on fixed incomes, so they can't afford a ride on the light rail or a cab ride. So fortunately, this partnership with Lyft allowed us to, bridge that gap and allowed us to bring those residents over to the site. Technological barriers. Early on, we learned that it was difficult to register to receive a vaccine for many reasons, just navigating the system, language barriers. So we quickly came together to do a call center. And so we had about 10 hours daily where we would receive calls. We had volunteers that were trained, and they would receive the calls and register participants. And that was about 30% of the participants for this event. So it was highly valuable to have that resource available. Also diverse and culturally competent staff and volunteers. We worked with the African American Nurse Association as well as the Hispanic Nurses Association to make sure that the room reflected faces of those individuals we were trying to get to come through our doors. We also had literature, my next point, education materials in multiple languages. If someone walked in and we didn't have a person that spoke the language, we had a phone line where they could speak to doctors or nurses to answer their questions. So we tried to be as sensitive in that regard as much as possible. Next slide, please. So gathering and assessing data. Questionnaires, surveys, focus groups, all great ways of doing so on a community level. We did have our own survey and questionnaire at our event, which I will share with you here shortly, but also the church. The church was great in doing focus groups. They have various ministries where they had candid conversations. What were their fears? What were some of the things that they were hearing? And so they had, these conversations, and then they gathered that information and took it back to a professional to get some answers and bring back to the group, or they would invite a physician to come to the group. So, lots of ways to gather information to help the community. Next slide, please. So I'm not sure if I shared in the beginning of the presentation, but when we partnered with Mayo, we had a target of 1,000 individuals that we wanted to provide vaccine access to. And so we fell a little bit short of that goal. Our total number was 813. And we did have our own survey. So out of those 813 individuals, 695 did do our survey. And so here are some responses. The survey was around vaccine hesitancy. And so one of our questions was the reason for getting the vaccine. 82% said family, 74% keeping the community safe, 55% get life back to normal, and then 8%, the doctor told me so. So this is not anything new. It's really validating what we're seeing with other data, but it's good to capture within the group that we're working with. Our next question, what changed your mind? 41% said friends or family, 28% wanted to travel, 16% school, work, or community organization, and then 7.5 faith-based leader. Again, back to that messenger, the trusted messenger. It is key in getting people to make their informed decision. So why were you against the vaccine? 68% said distrust of the vaccine safety, 54% concern of side effects, 53% pandemic, not that bad, and then 20% unsure on how well it works. Again, it's important because we can therefore provide the community with information. If there is distrust of the vaccine, can we send them literature, with information on, new development? So it's important to gather this information and share with our partners. We shared with Mayo so that they can continue to work on their equity, diversity, and inclusion departments and take this information to expand upon that. Next slide, please. So looking ahead, I think Zeta, I'm sorry if I'm saying it incorrectly, but she touched on a lot of these points as well. Continue to address social and structural factors that disproportionately affect underserved communities. I think one thing that COVID has done is really brought this to the forefront and has forced us to deal with it now. We've known that these issues are there, but we are now faced. The time is now to address these issues. Improve access to health literacy in underserved communities. So again, with literature, information, making it accessible, and also just in providing it in a way that people from all walks of life can understand it. And so, with Mayo approaching us, I think that is a huge step in the right direction, and more work has to be done in that regard. So continue to get innovative on how we meet people where they are. And so currently, we do provide food distribution events at least 3 to 4 times a month. And so what we've been doing is, we're having these events, and people are, casually mentioning, oh, I'm still not sure about the vaccine. So we have talked to some medical students who will now be joining us. And so they'll be, hanging out at these events to answer questions, to, if people are ready to get the vaccine, provide the vaccine, do kind of like a house call situation. And this is what we have to do to meet people where they are and get creative, and, to get people the access that they need. So lots of work to do, but we're going in the right direction, in my opinion. Next slide. So thank you. I hope that the information I shared is of value, and you can visit our website at fibco.org or email me at chiquita.taylor@fibco.org. Thank you.
Thank you so much, Chiquita. While any of the participants are thinking of their questions, we had one question here. They wanted to know, how is your specific organization funded?
Yeah, so we are funded through grants. I would say 30% of our funding comes from grants. Then the rest is from donations. So our donors, yeah, so that's, and sponsorships, events, about 20%. So, and, with COVID, it's become more difficult. But, we've been having these health fair events. We will be having a women's heart health event on October 2nd. Please check out our website and social media for that event. But we continue to, push health initiatives as much as possible because the community really needs it.
It sounds like we do. We need you. Thank you so much, Chiquita.
You're
Okay,
very welcome.
we're gonna move on to Dana Kennedy, the State Director for AARP Arizona. Go ahead, Dana.
Thank you, and thank you for having me. It's great to be here with this great panelist. And I came into the office today and my computer shut down because I don't come into the office all the time, and it wanted to update everything. So hopefully I don't have any computer glitches. So my presentation is on social isolation and loneliness in older adults. Next slide, please. So social isolation and loneliness are very serious and underestimated health risk that affect, I can't see everything, okay, sorry, underestimated health risk and affect a large percentage of the older adult community. In the United States, an estimated 25% of older adults in a community dwelling are socially isolated, while 43% have reported feeling lonely. Arizona has over 2.5 million residents who are 50 and older, and 63.6% of Arizona residents over the age of 55 are no longer in the workforce, putting them at even a greater risk of social isolation. And the trend for risk of social isolation in Arizona residents who are 65 and older has risen 32%, an increase of 8% from the year before. The next slide, please. Or I'm sorry, actually, that was 2012 to 2019. So the presenting problem is these numbers, while already alarming, are continuing to drastically increase as a result of COVID-19 pandemic and its associated stay-at-home orders and restricted nursing home visits. Since the COVID-19 pandemic, 2/3 of adults reported have experienced isolation, while a similar amount have also reported that a loved one has experienced social isolation as well. And you might remember how difficult it was last year for families. Residents were locked out, or actually locked in. Families were locked out. We had to do a lot of advocacy in order to get families to be able to reunite with their loved ones in long-term care facilities. And it was absolutely heartbreaking. And pretty much, for those who may not know, AARP Arizona, as well as AARP nationally, we are an advocacy organization that's at our very core. So we advocate for 38 million members across the United States and 900,000 members in Arizona. And so we work on public policy to be able to reduce some of this. So we pushed the governor to put together a long-term care task force. And we, after months of advocating, we were successful in getting that done. Once we got the task force, it wasn't long before we came up with recommendations to be able to get family members in these long-term care facilities. And there are 147 skilled nursing facilities that are overseen by CMS as well as the state. And then you have a lot of residential assisted living facilities that are right in your neighborhood where you may not even realize where people are living. And then we also have assisted living facilities. So all of them had different regulations. But pretty much all of them followed whatever the federal government was saying. And so I did stand with the governor when we shut down these facilities, but when weeks turned to months, it was too much. And we knew that people were dying in these facilities of social isolation. And when I sat at that meeting with the governor, when we were discussing shutting down the facilities, the very first thing I said is, if you shut them down, you've got to get technology into their hands so families can visit with them. Because if you can imagine not being able to visit with your mother or your father simply because they were in a facility because they needed more help that you were able to provide them with. So it was really hard. So if you could go forward to the next slide, please. So social isolation and loneliness are major risk factors that have been linked to both poor physical and mental health outcomes. Isolation and loneliness can increase risk of high blood pressure, heart disease, obesity, diminished immune system functioning, depression, anxiety, poor cognitive functioning, Alzheimer's disease, and mortality. And so that's why this pandemic has hit our elderly residents so hard, is because they were most at risk. And so many of them, some of us might have gone about our own lives. They were locked in their house, wherever that house may be. Families, didn't go visit them. They were fearful that, you unknowingly could have given them COVID. It was really hard. So social isolation has also been associated with an approximately 50% increased risk of developing dementia, a 29% increased risk of incident coronary heart disease, and a 32% risk of stroke. And studies have shown that the risk of prolonged social isolation is the equivalent to smoking 15 cigarettes a day. Next slide, please. So the gap in care, social isolation isn't one of the topics that pops up during recent visits to healthcare professionals since the start of the pandemic. I would say more are actually starting to ask about this now. Despite the adverse impact of loneliness and social isolation and quality of life, there's strong association with health outcomes. The evaluation of loneliness and isolation have not been integrated into medical care. And to date, there has been no uniform way of evaluating and documenting loneliness or social isolation as part of a review of a patient's social determinants of health. The next slide, please. So one solution is increase awareness, public awareness and education campaigns. And I would say that was one probably silver lining of COVID, is this has been talked about more than it ever has been before. Increase and fund research at levels that reflect their association with mortality. Solution number 2 is integrate current research into healthcare practices. Healthcare providers need to periodically perform assessments to identify older adults experiencing isolation in order to provide a potential intervention. Transportation, social programs, online classes, and community outreach. That's solution number 3, increase community services. So when I first started with AARP, at the time it was Councilwoman Kate Gallego. She contacted me and said, we're really concerned. We're looking at this transportation initiative, which was Prop 104, and we don't have people talking about seniors. And I don't know about you, but to focus on what every single city is focused on, what the state is focused on, what the federal government is focused on, I was happy that she called me and alerted me to this, because when we're out in the community and we ask our members what's one of their concerns, transportation is one of the biggest concerns. And imagine if all of a sudden one day you no longer could drive. And so transportation is really important to our members. And usually by the time, I think it's 8 years, a man will not drive a car at the end of his life, and over 10 years, I believe, for a woman won't drive a car. So we actually supported that proposition, and it did win. We supported them trying to overturn it, or we opposed them we supported them trying to overturn it. And so we've been advocating for transportation because it's so important to our members to decrease social isolation. Next slide, please. So AARP is leading the way. We have become a leader in providing resources, recommendations, and solutions to combat the issues of social isolation and loneliness in the older adult community. And one way we do this is the organization that the part of the organization that I work for is actually the advocacy part, which is a 501c4. So we do unlimited amount of lobbying, but we also have a foundation, and our foundation has done a lot of research on social isolation and connecting people to and connecting people to programs and services, and really highlighting how important this issue is. Next slide, please. So AARP, what are we doing? Our foundation has created a website, Connect to Effect, which offers tools such as social isolation assessment, a local assistance directory to help find resources to combat social isolation in your area, ways you can volunteer and connect in your community, research and case studies on the effects of social isolation. People may not know, but we actually created a website called Create the Good. And so if you're a nonprofit organization that's looking for volunteers, you can register your organization. And then if you're a person who wants to volunteer, you can actually be matched. It's like a matchmaking service for volunteerism. And so it could be, you know, where you want somebody to volunteer with your organization every single week, or maybe you're just having a one-time event. And so I did this I went on the website over the holidays because, you know, we were told to stay home. And so I live alone and my family's in California. So I stayed at home over the holidays. So I volunteered almost every single day during the holidays in order to, you know, to help out, and to create the good was great. And so we also, during this program, we also created an opportunity for people to volunteer and call people who wanted a check-in call once a week. So we have volunteers that are connecting people who are socially isolated. And their phone number doesn't come up. It's called Dialer Hub. And then, you know, you're not always going to get the same. If you wanted a caller, you're not always going to get the same exact volunteer. We don't have the technology to be able to have the same one, but we want to make sure that we keep people's phone numbers private. So that's the only way to do that. The next slide, please. So AARP is doing in community outreach. So AARP helps fund a dozen programs nationwide that provide services to help older adults stay connected and informed. We also do that here in Arizona. So you'll often see that AARP is sponsoring different events, and we also have our own events. AARP sponsors and runs hundreds of local events such as movie screenings, yoga, music classes, workshops on a variety of topics that give older adults the opportunity to stay connected with members in their own community and beyond. And we also have a community over 60,000 volunteers, a majority of whom are 50 plus, who get involved with causes and programs to make an impact while socializing with other members of the community. Prior to COVID, we actually did a weekly walk, run, bike ride, and I actually led it. I am a triathlete, and so we would meet at Spoke and Wheel. We're a little sad that Spoke and Wheel went under, and it's right on the canal. So we would teach everybody to use the canal, how to use a multi-purpose path, to walk in a group. Afterwards, we would have dinner and we'd have some healthy food and everybody could have a drink of their choice. We do healthy rhythm drum circles. We are now doing those actually virtually. We also do programs with the city of Phoenix. They were at Hans Park where we did instructor-led cardio classes. And we continue to do that virtually. We've also added yoga. We do some flute classes for brain health. We partner with the City of Phoenix Jewish Family Services, where we have an instructor who basically works with the caregiver as well as a person who may have dementia, and they do some type of programming to reduce the social isolation. And then we just have volunteers. Even during this time, our volunteers have been writing cards to people who live in long-term care facilities. They've been baking up a storm and taking those cookies to first responders, firefighters, police officers, as well as people in long-term care facilities, and just different ways to be able to let people know that they are valued and that they are cared for. And you know, a lot of these ideas come directly from our volunteers. We've also been providing water for the shelters and hand sanitation. We also do community challenge grants. So if you're an organization, you've got an idea that you want to connect with the community to improve your community, we give these what we call like micro grants. And so one of the organizations that we're funding this year are with the Navajo, I think it's not YMCA. I'm sorry, I'm forgetting which one it is, but we're providing bus shelters for all the bus stops on the Navajo Nation. And then we're talking with them and they said, we could also use some resources for fire extinguishers and teaching people how to use fire extinguishers. It's a YMCA that we're working with. And so we're actually providing fire extinguishers and then teaching people how to use them. So if there were a small fire, it wouldn't get out of control. So, you know, we look at different ways of how we might be able to help and also provide opportunities for volunteers. The next slide. So transition during the pandemic, again, AARP Foundation has conducted studies to explore and report the impact of COVID-19 pandemic has had on social isolation. And so you can actually, since the beginning of COVID-19, the pandemic, AARP has transitioned to online events in order to allow for continued connection and engagement. If you wanted to get an idea of some of our events, you can go to our website, aarp.org or aarp.org/AZ. And we also have a Facebook page, AARP Arizona, where we talk about a lot of our different events. We also join forces with Older Adults Technology Services to provide technology and device training, including 26 weeks of curriculum modules to help older adults thrive in the digital world, to utilize technology and the available online resources to improve their social engagement. And we also became the Friendly Voices program, which I talked about earlier, to combat social isolation, where you can request a call from one of the many volunteers to chat about resources or just to hear a friendly voice. And you can call 1-888-281-0145 and leave your information to receive a call back. Next slide, please. So AARP Arizona, stay connected locally. We have several upcoming and ongoing events to provide opportunities for members in the Arizona community to stay connected. We do the AARP Arizona Music and Memory Care workshops, movies for grown-ups, virtual happy hours. We actually do a hip historian happy hour. It's at 7 o'clock every Thursday with Marshall Shore, the hip historian. And he's a hoot. I mean, if you want a good program on a Thursday night, they have a cocktail every Thursday, a new cocktail, and talks with the historian, and you'll find all different really fascinating information about Arizona. And then we also do music jam sessions and just so much more. So you can find out about events in our area just by going to, it's really just aarp.az. You can also go to aarp/Arizona/events-az. I think that's the last slide, except maybe so empowering people to choose how they live as they age. And for more information, go to AARP Foundation website on social isolation at https://connect-to-effect.org. And the next slide. So these are just references of where we got our information. So thank you.
Dana, thank you so very much. You may have answered this question. Someone wanted you to share the slide about, let's see. Thank you so much for bringing attention to just how much damage was done to our elderly population during lockdown. Can you share how to volunteer? Was that the Connect website that you just showed?
That might have been the Create the Good. If you go to www.createthegood.org, that's kind of our volunteer matchmaking website. And if you're an organization who wants volunteers, we're not the middle person in this. So you just register your organization. And if you want to say, I want to volunteer with children, then your organization may come up. Toddlers, basically you want to work with the homeless, you want to volunteer with the homeless, whatever population you want to work with, it will come up with the different volunteer opportunities. Or you can just say, I have Saturday free and I want to volunteer, and then it will populate all the different volunteer opportunities that are available to you on a Saturday or the day that you want to volunteer.
Okay, one other person was wondering if you could put up the slide again about what isolation increased the risk of strokes.
I think that is, I don't have control of the slides.
Oh, okay. Nick, can you put that one up, how it increases the risk for strokes?
I think it's for back even more. I think it's like one of the very first slides. Yeah, right there. Right there. And then probably the next one.
Also, question for Nick. One of the participants wants to know how the slides will be available to participants.
It will be available on the website in the next week or so. We'll be sending out an email with the conference evaluations and continuing education.
Wonderful. That sounds great. There was one other question for Dana, and it says, what can adult children do for parents who are isolated and live out of state?
You know, I think that hopefully your parent has a device. If they have a device, then you can FaceTime with them. I think that helps them feel connected, or just calling them and talking to them. If you want to connect them to resources where they live in the state that they live, I would suggest that you go to whatever state they live in. There is an AARP state office, and every state office has different opportunities and different activities. People don't realize this, but we were in the community before the pandemic. We just now have shifted to do all online events. When it's safe, we can't wait to get back out there. I mean, we used to do monthly hikes. You know, I'm an active person myself, and I love to be with our members. We've done bike safety classes. You know, we just try to find something for everyone. And, you know, sometimes we were just doing caregiver happy hours as well, where if you are a family caregiver, you could just come to a local establishment and we'll feed you, we'll provide you with a drink, but we're also going to provide you with resources. And the other thing that AARP is really good, if you're a family person that is trying to figure out what to do with your parent, we have a great book called Prepare to Care. And then we also have local resources guides. And we have those local resource guides in all states for the most part.
Thank you. One other comment was great presentations by all three. So many best practices highlighted. Thank you for sharing. At this time, are there any other questions, either for Chiquita Taylor, Zeta Didolf, or for Dana Kennedy from any of the participants? If not, I will turn it back over to Nick.
Very good. So that's going to wrap up our conference, the 2021 conference. I want to thank all the speakers and moderators for their informative presentations. Please remember to look for the conference evaluation and continuing education email that'll be delivered in the next few days. And lastly, I want to thank you for attending and look forward to seeing you in 2022.